My name is Paul Rosenstock. I'm an internist and geriatrician and medical director and CEO of Doctors on Call, which is a group that services the homebound elderly. We have 70 practitioners that service the homebound elderly. It's been around since 1968, and we have a lot of experience in dealing with this topic, so we're going to try and give you some of the essence of what we've learned in dealing with this condition. How often do you see this? Help. I fall and I can't get up. We get this at least once a month, maybe more. And it's a condition that is so prevalent, falling is so prevalent, and does so much damage that we have to be able to sensitize people to the significance of this and how to prevent it on an urgent basis. First of all, what's a fall? A fall consists of 2 or 3 components. One, a rapid moving downward. Someone's body is rapidly moving downward, freely, and the most important thing is without control. The person has no control of where they're going to fall or how they're going to fall, and obviously from a higher to a lower level. Why is fall prevention so important? A third of the seniors 65 years or older will fall one time this year. 1/3. A third of nursing home admissions are due to falls. 1/3. And why do seniors fall more than others? Some of the reasons are obvious, but there are increased risk factors related to balance. As we get older, we lose our ability to balance ourselves more. And there are traditional risk factors, such as things that are outside of us, things that we can change and not change. But the most important risk factors are broken into 4 categories, which we'll discuss later: age-related, behavioral, environmental, and community policy. And there's no need to remember them because we'll go into each of them. And by the way, if you stop by the Doctors on Call table, we'll send you a copy of this presentation, as well as a fall prevention screening tool and a list of medications, common medications that are used by most people, which can result in falls. Falls are the leading cause of external injuries. Children less than 5 years old and people over 65, 50% of them will occur in the home or in the immediate environs. Half of all falls occur in the home or immediate environs. Falls are responsible for 70% of accidental deaths in people over 75 years old. 70% of the people who die, who are over 75, will die because of a fall. And 25% of the elderly who fracture their hips die within 6 months of the injury. 25%. What happens when a person falls? Well, more often than not, a hip fracture results. 250,000 Americans in 1996 had fractured hips. Number is probably much higher now. This is data from 1996. 90% are associated with falls. At that time, in excess of $10 billion was spent just on hip fractures. And it was the leading fall-related injury resulting in hospitalization. 1 in 4 people who have a hip fracture, after they have a hip fracture, have to go to a nursing home and stay there for more than a year. Some never recover their balance and strength, and many often, because of that, because of the confinement, they become depressed and dementia ensues. 25% of the elderly people who fracture their hips die within 6 months of an injury. And listen to this. Someone who's been on the floor for an hour after fracturing the hip, the mortality is 50% because of what they call a long lie. Someone who's been on the floor for an hour after fracturing the hip, unable to get up, that in and of itself is associated with a 50% mortality. Another consequence of falls is traumatic brain injury, especially Can anyone guess what medication is the most medication associated with falls? Coumadin. Coumadin will result in bleeding into the brain if the person sustains a severe head injury, and doesn't have to be externally manifested. I've had patients who 2 to 3 weeks after having fallen are brought in with a subdural hematoma, a blood clot in the brain, because they were on Coumadin. It didn't come out till I have a chavrusa who wasn't on Coumadin, who had a subdural hematoma after an auto accident where he walked out perfectly fine, and 3 weeks later he had a hole in his head to take out a blood clot. The cost of falls is enormous. $20 billion in 2000. And then that doesn't figure in the indirect costs. For instance, a son who has to take off work to help his mother or father because they've fallen. The productivity and quality of life drops, and people lose their independence, become depressed. And the estimated cost of falls in 2002 was over $32 billion. It's probably over $50 billion now. What causes falls? What are the risk factors? There are the traditional risk factor categories which we discussed before, where those can be changed, those who cannot be changed, those which are intrinsic, that are due to the patient themselves, those are extrinsic, which is environment. Well, these things overlap. There's no way of putting a risk factor in one of these categories purely. So what we've done is we come up with other risk factor categories. Age-related and biological. As people get older, systems break down. The inability to balance yourself increases. And you are on more medications. And people have increased medical conditions, all related that can cause falls. People become more behaviorally dysfunctional. Cognitively, due to Alzheimer's, due to dementia, resulting in falls. The environment becomes a risk factor. Throw rugs, garbage, poor walkways rather, are all causes of falls. And finally, how we handle falls with our community policy. The sidewalks. Walk along the sidewalks in Flatbush and see if when you're normally walking you don't trip. Some of the medical conditions that can cause falls: stroke, incontinence. People who are incontinent have a predilection for falling. People have Parkinson's disease. Their gait is very shuffling. They cannot move, and they can't move in reaction to loss of balance. Neuropathy, people who can't feel their extremities. Diabetics, who lose their ability to understand where their feet are. And people who are weak. Poor general health. Diabetes, as I said. People who have joint problems. They cannot use their lower extremities to catch themselves if they're off balance. People who have osteoporosis, and finally Alzheimer's disease. The number one cause of falls in the United States is medication. Sensory perception, the ability to hear, to see, to feel appropriately, balance and gait impairment, mental health issues, and a lack of exercise. I was just approached by someone in the hall outside, and he said, my mother used to get out once a day, used to go to walk to the corner, to the grocery store, no longer does that. How can I deal with it? Physical therapy is an extremely important tool that can be used to increase the person's ability to exercise. Footwear. Get a person to a podiatrist. Why? Because very often they're wearing the wrong shoes. You'd be surprised how many people who are elderly drink once a day, 3 times a day. How many of the elderly have good nutrition? This very same individual admitted to me that his mother doesn't eat well anymore. Does she have low protein? Does she have vitamin deficiencies? What about her vitamin D? What about the calcium? As people get older, they tend to drink less. they become more dehydrated, especially in the summer. And they lose consciousness because of that. Very often people are afraid of falling. And the fear of falling itself induces falling. And where do people fall? Well, as I said before, 50% fall in the home or around the home. 30% in public areas, 10% in healthcare facilities. Now someone's going to ask me, where's the other 10% that's missing? I don't know. But they fall somewhere. Clutter. How many people have lamps and the cord now strings along the floor? How many people have drawers that are open? What about toys? You have your grandchildren over and there are toys there around. And a person gets up to go to the bathroom and they trip over the toy. Poor lighting. Lack of handrails. The elderly need different types of toilets. A toilet that's for a 30 or 40-year-old is not good for an elderly individual. And we'll talk about how you evaluate that going forward. Items that are hard to reach. The elderly person doesn't have the same reach span that we all do. And therefore, they'll step on a stool if they can't reach something. Or they'll bend over and lose their balance. Obstacles in the paths. Go to the country and you see pathways that are strewn with all sorts of obstacles. Bicycles, the scooters. And the elderly get out, they go want to visit their grandchildren, and they fall and trip. Area rugs. Very often people have area rugs in the home and they're not taped down. And the edges are not taped down. And therefore a person will trip on them as they go over to the drug area.
What can you do about that?
Nail it.
Nail it?
Nail it down.
What?
Nails. You have wooden floors and you nail it through the carpeting, or you tape the edges. Yeah, tape the edges. Also, we have to talk to our community leaders. You walk along the sidewalks of many of our Jewish communities and you'll see that the sidewalks are askew, that roots have pushed up the concrete, that there's levels that are different from one concrete block to the next. All risk for falls. Walk along Woodmere and Flatbush, you'll see this all throughout New York. There should be, there is a law, but it's not enforced in terms of leveling the sidewalk. Cracked sidewalks have to be repaired. Handrails. How many staircases in our homes, have handrails only on one side? The person who's walking up or lurches to the wrong side and doesn't have a handrail to grab onto, now is bereft of the ability to steady themselves, and they'll fall. Establish referral systems and resource networks for seniors. Seniors very often don't have adequate resources to be able to deal with this. The person just asked me before in terms of how do I get a raised toilet with grab bars? Will the insurance pay for it? We have to lobby our individual insurance companies to be able to do that. Some do, some don't. Now let's get specific in terms of what the risk factors are. What can we do about this? First of all, you can't do anything about increasing age. Hopefully we won't do anything about that. Living alone. People who live alone have a tendency to fall. Why? They leave objects around. And they do things in the home that causes themselves to fall. Spills that don't get picked up. They'll trip on that. Anyone who's had a previous fall is at risk for another one. If someone has had a fall within the past year, they're at risk for falling again, greater than the rest of the population, 1.5 times greater. If someone uses a cane or a walker, even though that is designed to prevent falls, they're at risk for falling. And therefore, those people have to be extremely careful in terms of use of that cane. They misplace the cane in one area that could also induce a fall. They're thinking that they're secure, they're not. Someone has an acute illness, obviously can cause falls. And then you have different types of reduced vision. Someone has sudden glare on them, they may fall. They'll lose their perception of where they are. Altered depth perception. The person thinks that the stair is over here when it's really a few inches beyond that. They step in that direction, they'll fall. Decreased night vision and decline in peripheral vision. They think an object is not there when the object actually is there, and they'll hit into it. Now, medications. How many people here know of an elderly individual who is free of medication? None. Some elderly individuals are taking 10 or more medications, and they include antidepressants and sedatives. Physicians today do not reduce medication. If a person is on an anti-anxiety agent, take it morning and night. They'll refill a prescription over and over and over again. Does the person need an anti-anxiety agent all day long, every day, or only when they're anxious? Do they need the same dose? Taper the dose. Are the things that cause stress in their life the same as they were 3 years ago when you prescribed it? No. A person who's on an antidepressant, can you wean them down to a lower dose? Change it to a less toxic medication? This is not done. The caregivers are not familiar with the medication regimen that the patient's taking and whether or not you can intervene. They're scared to ask the physician, well, why does my mother need an antidepressant for so long a period of time? Why does my mother need to be on an anti-anxiety agent morning and night every day of her life? As I said, there are antihypertensives and cardiac medications that can cause falls. Hypoglycemic drugs which are used for treating diabetes can cause falls. You'd be surprised how many elderly drink alcohol. And let's talk about bladder dysfunction and nocturia. Nocturia means simply the ability to get up the desire to get up at night to urinate. Very often people get up at night to urinate 3 or 4 times at night. And the most common occurrence of nocturnal falling is going to the bathroom. Why? Why does that happen? When a person gets up from a lying position into a sitting position, the column of blood is now, which was horizontal, is now vertical or semi-vertical. Gravity pulls that blood down. Our bodies are designed, because Baruch Hu gave us very good bodies, and what happens then is that the blood vessels in the lower extremities constrict and force the column of blood up. The elderly don't have that ability to do it fast. They still have that ability, but they can't do it in the same fashion that you or I can do it. And so therefore, when they get up from a sitting position and then rapidly go to a standing position and then go to urinate, which induces another drop in blood pressure, they'll fall, lose consciousness, and have a serious injury on a hard tile floor in the bathroom. Or hit their head on the sink on the way down. The elderly have to get up, sit in the position for a minute or two, go to the bathroom and urinate sitting down on a toilet seat which is raised, which has grab bars on each side. So therefore, now you've reduced you've given the body the ability to be able to put that column of blood vertical and circulate blood to the brain. Poor footwear and foot conditions. People who have pain due to bunions, people who have corns and calluses and foot deformities, all are subject to fall. Not because they have bad shoes, but because they don't step right, because they're trying to avoid that area which is causing pain. What's going on here? Sorry about that. It's not moving. Oh, here we go. Okay. All right, we've gone through some of these risk factors for falls. I'm not going to go through them again. Oh, one important thing. How can you determine if your elderly relative is able to negotiate getting up and walking around without falling? There's a simple test called a Tug Test. Timed up and go. Tug. You ask a person, you're sitting in a chair, get up, come to me, I'm 10 feet away, turn around and go back. Sit down. If that person can do it in less than 12 seconds, they're fine. Greater than 12 seconds, they have a tendency to fall, because their musculature does not allow them to perform this activity in a rapid fashion as needed. So that's a very simple test. You can do it on yourself, on anyone. If it takes them more than 12 seconds to get up, walk 10 feet, and get back and sit down again, that is a tendency to fall. That describes a tendency to fall. Cognitive impairment. Someone who has a deficit in memory, visuospatial skills, executive function, all of those contribute to the ability to fall. someone who has progressive decline in dementia, or delirium, which is a rapid onset, and by the way, that's a medical emergency. Someone who rapidly changes their personality, rapidly changes their ability to relate to you, you have to suspect that something is going on, which is a medical emergency. Now, losing consciousness, which the fancy medical term is called syncope. Someone faints, that's syncope. There are three main areas. There's vasovagal, which means that the blood vessels are dilating because of the vagus nerve is suddenly discharging. And that can happen when someone's standing in a crowd on a hot day. And you'll hear about these stadium incidents where somebody's fainting, or someone goes to a rally and it's a hot day and they'll faint. Why they faint? Because the fact is that they are losing their vagus nerve suddenly discharges. They can't. The blood drains from their brain and they'll fall. Someone who's on blood hypertensive medication can have orthostatic hypotension, where the blood pressure will drop suddenly, their brain won't get perfused, and they'll fall. And a very rare condition, but we see this once or twice a year, is someone who has carotid sinus syndrome. What is that? That is when the carotid nerve in the neck suddenly gets compressed by someone wearing too tight a collar, and they're suddenly turning their head. And the carotid bulb will get pressed, the vagus nerve will discharge, blood will drop from the brain, and they will lose consciousness. Dizziness and vertigo, the sensation of suddenly that something is not right or that the room is spinning, these are all causes of falls. And now what can we do? How do we deal with this? It's such a huge problem, results in such serious injury, it's so common, and we're all getting older, or we have people that are getting older that we're associated with, and what do we do about this? The first thing to do is make sure they get to a geriatrician. Make sure they get to someone who's familiar with the problem. Someone who can do a cognitive evaluation. And make sure that their vision and their podiatric exam is done. Do a home safety evaluation. Get someone in there who's skilled at doing that. Looking for things, and you can do it yourself. Where are the rugs? Are the drawers open? Are there electric cords around? Does the person have easy access to everything they need to reach to? What about getting up and going to the bathroom? Do they have a raised toilet seat? Do they have grab bars in the shower or in the bathtub? Make sure that if they're on psychoactive medications such as antidepressants or sedatives, that the physician is weaning them from this medical regimen if possible. Make sure that the anti-anxiety agents are used intermittently when the person is anxious, not as a preventative for anxiety. And review and get to know the medical regimen. If a medical regimen is being changed every 3 months, which very many regimens are, make sure you know about that. A lot of people have osteoporosis. As the bones deteriorate, our posture deteriorates, our musculoskeletal response to changes in our balance deteriorates. This can be ameliorated with physical therapy and exercise to some degree. Vitamin D and calcium supplementation needs to be done. Now, who's at risk for medication-induced falls? Anyone who's on more than three types of medication. If you have four or more types of medication, person's at high risk for falls. Someone who takes more than 12 doses of medication a day. I got to take one in the morning and one at lunchtime and at nighttime and in the afternoon. Someone who's had a change in their regimen in the past 3 months. If they're seeing many doctors, I'm seeing the neurologist, I'm seeing the cardiologist, I'm seeing a foot specialist, they're all giving me different medications, and these medications may conflict and may induce falls. Again, as we talked about psychoactive medication, someone who's been recently discharged from the hospital. At Doctors on Call, we do something called Transitional Care, where we see patients within 1 week of discharge from the hospital. We walk into the home, we find a medicine cabinet full of medications they've taken for the past 7 years, a set of medications their doctor has given them for the past 3 months, and a set of medications that the discharge doctor has given them in the hospital, and they don't match. And so we have to do something called medication reconciliation, throwing out the ones that we actually go in with garbage bags, and we throw out the medications that can be harmful or useless, and give them a solid medical regimen that they need to take right from that point on. Someone who has multiple medical conditions that require medications are at high risk for falls. And then there are people that, I'll take this medication on Monday, and I may take the other one on Tuesday. I don't know, I'll see how I feel. And if my heart's too fast, I will take the beta blocker. I won't take the beta blocker if I feel I'm too sluggish. They play around with their medications. And you know that by virtue of the fact when you come in at the end of a week, you'll find this medication regimen, this bottle has gone down this much, but this one is still full. So you'll be able to tell right away that they're playing around with their medications. Those people are at risk for falls. And finally, medications with narrow therapeutic index. What do I mean by that? Coumadin is the classic one. Coumadin is a medication which is called colloquially a blood thinner. It doesn't thin the blood, it prevents clotting of the blood. And this medication has to be very carefully monitored. Sometimes the clotting effect can be too large, sometimes it can be too small. And it has a very narrow range, so it has to be carefully monitored. Some people escape this range, and their blood will become quote-unquote too thin, or the ability to clot will disappear. These people can bleed easily. If they fall and hit their head, they'll bleed into the brain. Or if they fall and hit their body, you'll see a huge blood clot forming underneath their skin. So those medications with a narrow therapeutic index, digoxin is another one, are medications which really have to be carefully monitored, and if they're on this, the person has an increased ability to fall. Again, we talked about the Tug Test, timed up and go test. There's a fall screening tool that if you go to Doctors on Call, we'll send you a fall screening tool, and you'll give us your name and email address. We'll send it to you, and we'll send you a list of also the medications that the common medications, which are in the hundreds, but they're grouped by category, which can cause falls. Again, postural hypertension, the ability that people's blood pressure drops when they get up too rapidly, and if they're taking 3 or 4 prescription medications, and you have to look at those medications and treat the osteoporosis. Preventing falls in the home, remove the throw rugs. Secure the carpet edges with nails, with tape. Remove the clutter. Get rid of all the toys. Keep the toys in one area where the kids will play, where the grandkids will play. And remove the cords and wires from the floor, and avoid floor wax. Push in the drawers. Make sure there's lighting. There's adequate handrails. Eliminate chairs that are too low to sit. An elderly individual who sits on a low chair has very great difficulty in getting up. Keep used items in cabinets that can be reached easily without using a step stool. And wear well-fitting shoes with slippers with non-skid bottoms. Wear sneakers. Put grab bars in the showers. Use rubber mats in the bathtub and showers. Install a raised toilet seat. And keep the drawers closed. And outside the home, make sure your sidewalks are repaired. Install handrails on the steps and to make sure that each set of steps has handrails on each side. Make sure the shrubbery doesn't grow into the pathway. Make sure it's well lit, and use the appropriate assisting device. And finally, what happens if someone does fall? What do you do? Someone fell. What do you do? Make sure, number one, that there's no ongoing danger. If they fell and there's rubble and there's more rubble that pile on them, make sure that that's prevented. The second thing is check if they're responsive. Is the person responding to you? Do they have an adequate airway? ABC. Are they have an airway? Are they breathing? And is there circulation? How do you know if there's circulation? See if there's a pulse. And if the person is responding, reassure them. Don't let them get up right away. Check for injuries. And if there is an injury, call for help. Don't try and move the person yourself.
What if they live alone?
We'll talk about it. It's a good question. We'll talk about it. You monitor the person, and how do you monitor them? Call them every day. Make sure that their mentation is the same as it was 2 weeks ago before they fell. And because I said some injuries may not be apparent. And also report the fall. Make sure that the doctor knows about it. Make sure the relatives know about it. And make sure it's recorded somewhere. And then after the fall, make sure you try and figure out why they fell. All the people who fall are likely to fall again. Anyone who's fallen the past year will fall again this year. And perform a full risk assessment. We'll use that full risk assessment tool and discuss how to prevent falls in the future with the individuals involved. In summary, falls have serious consequences. They kill. Consequences of falls are serious. No minor injuries should be neglected. Someone who you think didn't hurt themselves, make sure you monitor it. We discussed about the factors, and also make sure you gauge the older person if they're with it. Engage them and try to prevent the falls. You know, Mom, you're not getting on the same way as you were before. Let me put a grab bar in there. Let me put some raised toilet seat. There may be some resistance. I want to take your dishes down from the top level and move them down below. Get them to buy in on that. It needs to be addressed where the person is being treated, and it has to have multiple disciplines. The geriatrician, the podiatrist, the ophthalmologist, the physical therapist, all have to be brought into the picture in this. And it has to be multifactorial in terms of looking at why a person has fallen. Remember, growing old isn't for wimps. The only way we'll be able to prevent injury is by being informed, and I hope you enjoyed the talk. Thank you.
Thank you.